Hello and welcome to our webinar on the 4 levels of FASD prevention, presented by Dr. Nancy Poole and Lindsay Wolfson. My name is Halima, and I'm the Executive Coordinator at Health Nexus. Health Nexus oversees several provincial initiatives relating to FASD. We allocate subsidies every year to over 40 support groups for individuals with FASD and their families. We designed an online training for service providers from various sectors, including healthcare and nursing, education, mental health and addictions, justice and corrections, and community and social work. And lastly, we manage the provincial FASD website, fasdinfo.tsaf.ca, where you can find recent and up-to-date information about what's happening, learn more about resources and tools, and find out services available in your local community. Some general housekeeping. We will answer questions after each presentation. Please ask them in the Q&A section, and remember not to use any identifiable information when asking your questions. We'd like to start off with a land acknowledgement. Health Nexus is located on territory that for thousands of years has been traditional homeland to the Anishinaabe, Wendat, Niuenwetio, Haudenosaunee, and more recently, the Mississaugas of the Credit. We are proud to take our part in the Dish with One Spoon Wampum Belt Convention, an agreement between the Haudenosaunee and the Anishinaabe and allied nations to peacefully share and care for the lands and resources around the Great Lakes. Health Nexus team members are grateful for the opportunity to partner with Indigenous peoples across Turtle Island and to work on this territory. Starting off with our presenters now, we have Dr. Nancy Poole. Nancy is the provincial lead for the CanFASD Research Network and recently sat on the scientific committee that prepared Canada's guidance on alcohol and health. She's the director of the Centre of Excellence for Women's Health, a research and knowledge exchange center hosted by BC Women's Hospital and the Health Centre in Vancouver. In that role, she leads network development, research, and knowledge exchange related to improving policy and service provision on a range of women's health and social justice concerns, including substance use issues. In 2021, Nancy was awarded an honorary doctorate of laws by the Justice Institute of BC in recognition of her contributions to women's health, including trauma-informed practice and the treatment of substance use and addiction. Our next speaker is Lindsay Wolfson. Lindsay is the research manager at the Centre of Excellence for Women's Health and a researcher at the Canada FASD Research Network. She holds a Master of Public Health, Social Inequities and Health from Simon Fraser University. Lindsay was responsible for research and collaboration on projects relating to women's substance use and stigma reduction, fetal alcohol spectrum order disorder prevention, Indigenous health and wellness, and the integration of gender, trauma, culture, and equity-informed approaches into policy, research, and practice. And with that, I'd like to pass on the baton to Nancy, Dr. Nancy and Lindsay.
Great. So thank you, Halima and Health Nexus and FASD Ontario for sponsoring today's webinar. Before we begin, we also want to recognize the land in which we're joining from. We are gathering from diverse territories across Turtle Island, and we want to acknowledge the First Nations, Inuit, and Métis people as the first inhabitants and traditional custodians of the lands in which we live, learn, and play. I am presenting from the same territory for which the territory recognition was already given, and pay my respect to elders past, present, and emerging from the Haudenosaunee, Anishinaabe, Mississaugas of the Credit First Nation, Mississauga, and Wendake Niuenwetio peoples. Nancy is joining us from the traditional and unceded territory of the Lekwungen-speaking peoples, including the Songhees, Esquimalt, and Wasanj peoples. And again, we pay our respects to the elders past, present, and emerging. So I'm going to pass it off to Nancy in 1 second, but before I do so, I just want to describe a little bit of what we're hoping to do today. We're going to start off by talking about what FASD or fetal alcohol spectrum disorder is and FASD prevention. And we will then dive into the most recent research available on the prevalence and influences of alcohol use during pregnancy, FASD interventions, policy responses, and the impacts of stigma. And at the end, we'll share some evidence-informed tools for practice that can support women and gender diverse people who use alcohol and other substances in the preconception and pregnancy period. You'll also note that in this presentation, we use a lot of gendered language. We are basing this off of the research, and this area of perinatal health is centered around women and girls, or at least that's the language that's been used to date. So with that being said, I will pass it over to Nancy to talk a little bit more about what is currently known about FASD.
So we thought we'd just start off with a few slides about what FASD is. I'm sure this is old hat to lots of you, but it is really important, I think, that we have a really strong linkage between an understanding of the disability and its prevention. And we're very committed to increasing those linkages as we continue to do this work on FASD prevention. So this is the definition that the CanFASD Research Network has been working on, that's on the slide here. And there's lots more written about this standard definition on one of their issue and policy papers. But I think it's really important that we have this kind of common definition of FASD for our work in the Canadian context so that we can reduce the stigma, increase understanding of this disability, have more consistency in our messaging, and have a strengths-based rather than a deficit-based definition, which is what we used for many years. So, it's prevalent in Canada, and I think it's really underestimated in many people's minds about how prevalent. And, 4% of the population is estimated to be affected. And I think that's so interesting that we have not had as much attention to this particular disability in spite of this size. And it means that almost 1.5 million Canadians may be living with the disability today. And of course, this may be really even underestimated because of the challenges about identification and measurement. So lots to think about as we go forth in its prevention in terms of linking it to this to an understanding of how prevalent it is. So the disability itself is really, I think, emerging. Our understanding of it is really emerging over time. And the many little colored things on the side are the domains that are used in the diagnostic and assessment process. And you can see, like, it covers so many dimensions of living. And so it's really important that we help people with diagnoses so that the kind of connection to services that are needed based on an understanding of their particular experience is there. So there are these 3 terms now used in the diagnostic process. 2 of them are diagnoses. The first 2, FASD with sentinel facial features and FASD without. And then there's a category that they're putting in place that's at risk for a neurodevelopmental disorder and FASD that is really associated with prenatal alcohol exposure and is really important in terms of monitoring and seeing what supports that group needs as much as those with the official diagnosis. So lots of work is being done on the diagnostic part, as I'm sure many of you are aware. But I think, a little less common is the understanding on the other side of how are we understanding alcohol use in pregnancy? And we created this little graphic many years ago now, and others have picked it up and reproduced it, like the prevention conversation in Alberta, etc. But I think what you're going to hear today is our work around thinking through how do we support and address all of these reasons or underlying factors that may be in place for women who use alcohol in pregnancy. And some of them are about the awareness side, but other parts are about these other levels of prevention that we've identified that really need, much more holistic and wraparound type of support. So we're going to talk lots about these levels and how they really tap into these reasons underlying alcohol use in pregnancy. So I think, we've really been anxious for everybody working on FASD prevention in Canada to know about this little image, right? That it isn't only about alcohol that we're trying to influence when we're doing FAS prevention. It's about these proximal determinants of health that have been so clearly shown to be connected to alcohol use in pregnancy, like poor nutrition, lack of access to prenatal care, being stressed, not having good overall health, and to be using a range of other substances. And then, of course, always taking into account the broader determinants of health, like exposure to violence and racism and experience of loss, isolation. We've included a few other ones in here to focus also on the positive around resilience, and also to point out the systemic determinant of health or structural determinant of health, like the way our policies on mothering can really be a barrier for women getting to the care that they need. So that's a really quick look at FASD and the challenges that we have around it. So now I'm going to just give a bit of an overview of what we've been thinking about in terms of these levels of prevention. This thing along the side on this one slide is actually an infographic that you can download from the Center of Excellence website if you're interested. It just talks about what we know about women's alcohol use, how it can make it challenging for women, what service providers can do, etc. So it's just a quick snapshot, but it may be of interest to you. So here's our four-part model. And, clearly we've been thinking about it for a long time. I think it was back in the late 1990s that I first wrote that document on the left there with the Public Health Agency of Canada funding. There's an update on that description of these four levels on the CanFASD research network. But I'm just going to walk through them right now, one by one, starting with the awareness level. And I think it's a really interesting one because people really underestimate how big the level one work is, because it can be so many different things. It can be about health education materials like posters that are some of them shown here. It can be about whole campaigns of awareness. It can be about having and making awareness of low-risk drinking guidelines overall. And as was mentioned in the introduction, we're going to talk a bit more about that because I had the opportunity to sit on the guidance committee this time around. It can be about having great materials for educators and facilitators of girls' empowerment groups so that that kind of discussion can happen in larger health promotion settings. It can be about warning labels on alcohol, containers and warning labels in restaurants and bars, etc. And it can be about full-on community development processes like we do around September 9th. So I think this is a really important area that used to be the only one that we started with in terms of thinking about FASD prevention. And then we realized it was a necessary but not sufficient thing for preventing alcohol use in pregnancy. It's, got some great things going forward. And I know that Health Nexus has been working on materials as well. So lots to be done there. The level 2 part is the part that I'm always urging people to take more seriously. This discussing alcohol with girls and women and their support networks by everyone, by every type of healthcare provider, not just doctors and nurses and midwives, and really thinking about what that might include. And, we often talk about these as brief interventions, but it's really important, I think, that we think about them as relational conversations where we develop, trust and safety to have the discussion, because otherwise it's really not at all likely that women are going to feel safe to disclose their level of alcohol use and to get the help that they deserve. So we really, see how it is important, whether the conversations are one-on-one or whether they're in groups or in talking circles or whatever format it's in, that we really find non-judgmental ways to talk about it. Make it a conversation. Ask her about what she already knows, rather than just barreling in to start saying, oh, it's this big problem, and et cetera, et cetera. That is more intimidating and less about listening to where she's at and her level of awareness. And to really, bring that sense of thinking about your values around your alcohol use and the implications for how you live your life. And I think we the new guidance on alcohol really tries to encourage that as well, of thinking about where are you in terms of level of risk, and how does that fit with who you want to be. Really encouraging small steps for change and talking about the benefits for her own health as well as her baby's health. So this is a huge area, I feel, that needs lots more thinking about and action on, and hopefully we'll be able to do lots more of that in partnership with Health Nexus and many of you from across Ontario. The next level is really about, wrapping care around pregnant women who have alcohol concerns and a range of other health and social concerns, like in that diagram we showed earlier. And these programs have really, example, Breaking the Cycle in Toronto, many others across the country that we've just recently studied. Here's 2 examples from Sheway in Vancouver and the Mothering Project in Winnipeg. But they do this combination of outreach and practical support and helping women reduce harms in a whole range of areas in their lives, including alcohol. They have integrated support around multiple issues that may be affecting women, like custody and housing and violence, etc. And that the care is wrapping around mothers and children, and really making sure that we're thinking about that next generation and how we can break the cycle of addiction and trauma and homelessness, etc., by really getting behind the mother-child unit. And always thinking about trauma, being trauma-informed and attachment-oriented. So these amazing programs have really modeled for us what it is to go beyond just having the discussion. For those who can stop having had a discussion in level 2, that's great. But many need this additional kind of wraparound support if they're going to be able to make changes during pregnancy. And then finally, the level 4 part is really important, that we don't just say, okay, now you've had the baby, see you later, that we really continue to provide support through home visitation, through parent-child assistance programs, and the whole range. I know there's a lot of advocates and mentors working in communities across Ontario that are really designed to help women continue to negotiate the service system to improve her health and the health and well-being of her kids. And some women who have addiction concerns, who whatever they've been able to do during pregnancy may well benefit from actual substance use treatment, either on an outpatient or a day treatment way or a residential way. And lots of these programs are really needed across Ontario and elsewhere. But, a lot is also being done in Indigenous communities and beyond. So that is kind of a whirlwind tour through the 4 levels of FASD prevention as we have been conceptualizing them and seeing them in action so far. And Lindsay's going to turn now to talk a bit more about some of the evidence behind this work.
Thanks, Nancy. I think it's really helpful that we have this model. And I think, some of you on the call today might be familiar with the model and might be interested in now what's the most recent evidence. And so that's something we do every year. Every year, researchers that are associated with the Prevention Network Action Team, the Canada FASD Research Network, collate all of the academic literature related to FASD prevention. And we use the 4-part model to organize and update those who are involved or interested in FASD prevention work to see what is most recent and what we're seeing most currently. So this is the annotated bibliography for all of the articles published in 2022. It started with, a meager 10,000 articles that we screened through. And in the end, there were 112 articles that were written about FASD prevention that followed this 4-part model, with most of the research coming from the US, Australia, Canada, and the UK. And as Nancy said, it really is not only about alcohol use. There are so many factors that are related to FASD and FASD prevention. And what we find most years is that at least a third of the articles really focus on the prevalence of alcohol use, including the factors and influences of alcohol use during pregnancy. And we see that, considerations like pre-pregnancy alcohol, tobacco, or other substance use continue to be risk factors for alcohol use during pregnancy. We see age both being younger, but particularly in a North American context, being older is a risk factor for alcohol use. Partners' alcohol use, violence, and the use of alcohol to cope are really crucial for us to consider and emphasize how we can't just do these interventions, these brief interventions alone. We have to consider effects of trauma and violence. And certainly there's been more and more research on adverse childhood experiences, the effects of having poor or low social support networks, or living in rural areas as factors related to alcohol use in pregnancy. In more recent years, I think what we're also really starting to see is the impacts of pregnancy recognition, the knowledge of FASD and the impacts of alcohol use during pregnancy, and external stressors as factors that are related to alcohol use in pregnancy. And at the end of the presentation, we'll walk through a couple of tools, including a preconception resource, but I think really highlighting that we can't just be talking about alcohol use once pregnancy is confirmed, but with all those that are using alcohol and also having sex. And certainly we see colonization as a continued risk factor for alcohol use during pregnancy. Similar to how we see a lot of research on sort of the prevalence and risk factors of alcohol use during pregnancy, we also see a lot of research on that level 2, those brief interventions. And there remains a deep interest in the efficacy of brief interventions. And we do see that brief interventions in community healthcare settings help decrease the odds of binge drinking, frequent drinking, and harmful alcohol use, and that these interventions are most effective. This study is from Australia that found that the brief interventions were most effective in the second and third trimester. But something we also see is that brief interventions are often only conducted as part of screening. And, part of what Nancy said is that we're trying to shift this. So that way it is relational in practice. So that way we're not just having these conversations in the first trimester when trust hasn't been built, but continuing to offer support. We also are seeing more research that's looking beyond physicians and nurses to engage in these discussions. So in 2022, we saw some articles on nutritionists documenting how they're well positioned to engage in these dual conversations around nutrition or supplementation, to also discuss alcohol use during pregnancy. So again, highlighting sort of the role that in Ontario, we have CPMP, what CPMP can have in engaging in these discussions, and an emphasis on opportunities like education and training and how different modalities can be used, such as doing community delivered or group-based interventions, or tailored brief interventions. In 2022, we also saw some more emergent areas like technology and complementary therapy. And I think oftentimes when we think about technology and FASD prevention, we think about it in sort of that level 1 context and sharing the awareness campaigns and sharing the posters and resources. We're also seeing a lot more on Instagram and TikTok or YouTube. And what research has shown is that a combination of these approaches can be the most effective in helping combat the pervasiveness of misinformation. That's not to say that there is not a lot of misinformation. So colleagues and I are doing a study right now on TikTok, and there is lots to be said there, but certainly using multiple modalities is a most effective way of reaching people to share information about alcohol use and FASD. We've also seen, I think, really in response to the COVID-19 pandemic, the emergence of virtual support. And we've seen this peer support program where participants were able to build their social support networks, healthy coping mechanisms, and the virtual safe space was really seen as something that was safe, and where participants were able to develop community. So giving us a lot more opportunities with the use of technology and how we engage in this work, hopefully not continuing to burden those that are working in frontline, but providing different opportunities for care. And lastly, we're really seeing the use of complementary therapies. And there was a study done on Second Floor, which is an Alberta-based program out of the Lakeland FASD Center. And in their work, they really saw how yoga, Reiki, drumming, and gardening were all a part of substance use treatment. And that study found that, when therapies were enjoyed, participants really looked forward to and saw how that could contribute to reducing their substance use. So it lets us think a little bit differently of what, substance use responses can look like versus maybe how they've more traditionally been conceptualized. And lastly, I'm going to show an old slide, and I think it's just a really important slide because in this year and in the last, 6 or so years, we continue to see this pervasiveness of stigma, and stigma towards those who use alcohol during pregnancy, and also towards individuals with FASD, their families, their caregivers, and their support networks. And so, I think it's always crucial for us to consider how stigma and how the literature has shown us that stigma can impact women's self-efficacy, their confidence to seek prenatal care or substance use treatment, their confidence to parent or seek support for parenting. And this can be out of their own, self-stigma, also out of fear of being judged by healthcare providers or social service providers, or out of fear of child removal. And so the result of this stigma, has this effect where providers might be reluctant or hesitant to ask everyone of childbearing age about their substance use, and only ask certain people who have been falsely stereotyped or misrepresented. And that has resulted in rather challenging practices. And so the impacts, if we were to ask everyone about their substance use, we would mitigate stigma, and also, I think, increase our own confidence to engage in these discussions and build the practice relationally. Certainly for those with FASD, stigma can impact diagnosis and lead to misdiagnoses. It can result in providers feeling unprepared to diagnose or support children with FASD or adults with FASD. And so it can impede the ability for individuals to receive the assistance and care that they need. And certainly the public and media's representation of individuals with FASD can really detract from services that are available. And this rapid sharing of misinformation can be really challenging. And so I think there's a lot of work for us all to do. And we're so grateful for everyone who's here today to have sort of these open and honest conversations and raise awareness about what FASD and what FASD prevention can look like. And lastly, as Nancy said, when she showed that diagram, we can't just think about individual level factors. There is a lot that's been published, particularly in the States, on policy implications. And, one thing we're seeing, this was from South Africa, where there was a ban on alcohol sales during the pandemic. They saw that they had short-term effects on reducing their alcohol use. So quite a profound effect. Certainly not something that we can see that might happen here. But as we have the release of things like the new guidance on alcohol and health, what these considerations might be when we have policies that are harm reduction oriented, that are, based in evidence and information, and moving away from sort of the policy space, which has been quite fetus and child centric in its discourse, so that way we can move towards supporting mothers and people who are using alcohol during pregnancy. And if we are able to do that, we can better address sort of these punitive policies, but also the adverse effects that come from the punitive policies, such as increased alcohol use in pregnancy, increased odds of lower birth weight, and decreased odds of obtaining prenatal care. So that was a lot to say about, both what FASD and FASD prevention are, going through the four, and now the evidence. And what we're hoping to spend the rest of our time today is talk about some of the evidence-based approaches. So I'll pass it back to Nancy.
Yeah. So this colorful diagram is called 10 fundamental components of FASD prevention from this women's health determinants perspective that I talked about at the first. But I think it's a really, it's something we started to think through at a meeting that we had back in 2009 or so. And we've refreshed the document recently to show the evidence that's been building over time for bringing these components into FASD prevention. And it can be downloaded from the CanFASD website. But I think it's really important for us to be aware of this and doing this being comfortable with this sort of level of multitasking, of recognizing that we can be using an FASD informed and disability lens, even as we do FASD prevention, because there will be women who have FASD themselves, who also need to have the discussions with and to support planning with. So it's just a big lot of ideas that have strong evidence base over the decades since we first conceived of it. So just wanted to spend 1 second on this new guidance on alcohol and health that was released this year, and to point out that there are key messages for prenatal and postpartum periods in it. And I think, it's great. I think what's also good is to be using this as a general discussion for all people before pregnancy, after pregnancy, partners, women, support networks, to be thinking about our relationship to alcohol overall. And you can see the message on the top here from the guidance, which is, given the risks of violence and death and cancer and accidents and a whole manner of risks related to heavy alcohol use, they're really suggesting that we place ourselves on this continuum of risk and really adjust our alcohol use accordingly. I just want to stress before we go on that this guidance does not say anything about drinking only 2 drinks a week. It says instead that risk begins at the point of drinking 2 drinks a week. And that we should really, and increases as we go along. And for women, after 7 drinks a week, the curve, for risks rises really much more steeply than for men, given our different metabolism, our different body size in general, a body fat ratio of water and fat, etc. Many, physical reasons why women have to really think about this risk continuum, and to not be trying to keep up with male partners, because it's not a level playing field. So I'll get off my soapbox here, Lindsay, and let you carry on with more of the evidence-based approaches.
No, but I think it's important. I mean, because you're dispelling misinformation even in the webinar itself, which is so crucial as we talk about how pervasive it is and how it's so necessary, but also because it really does relate to how we think about brief interventions and how we have these collaborative conversations that really are relational. And I think there's a lot of trepidation in how we can engage in these. And so I've included up on the slide here, this is a resource called Doorways to Conversation. It's available on our website, the Center of Excellence for Women's Health. And it was all about brief interventions on substance use for a range of providers. So we worked with 8 different types of providers and talked about, what might be most relevant to their practice. And so, if you're new to engaging in these discussions, there are checklists even that you could use that you may say, I could talk about alcohol and tobacco, or alcohol and nutrition, or sexual health, or any of these things, just to increase your own comfortability and really, ground yourself in the foundations. When I talk about brief interventions and when Nancy and I deliver longer trainings, I often use the language that brief interventions are just having a conversation with a human. And I think that, Doorways to Conversation grounds that in much more evidence than that simple synopsis, but is really helpful for us to think about. And when we are able to, not just focus on alcohol use, I think it also breaks down a lot of the barriers in having these discussions, because we're able to link in things like mental health concerns or safe contraception and reliable contraception, or housing, and address multiple issues simultaneously, and including where reducing their alcohol use may not be their first priority. It may be access to housing or access to nutritious food, things like that. And so we're able to better support clients if we, can shift these and do these in sort of a dual, multi-topic capacity. And these discussions don't have to be one-on-one. They also can be done in group settings. Particularly in Indigenous communities, we're seeing more and more research and more communities that are telling us about using group-based approaches as, a safe way for them to discuss substance use, but also having these discussions around substance use where women already gather. So, for example, in some communities where there's land-based programming, discussions around alcohol use are just embedded into, what's happening on the land, and they're just part of building the relationship without putting judgment or onus or pressure. So they're really a feasible option, and certainly can be done in partnership with nutrition, pregnancy programming, school capacities, etc. And of course, we do see, in how we can move forward, technology can be used, and things like these webinars or virtual trainings really allow us to learn more. And on our website, we also have a link to this international seminar series, which walked through and had examples from every single level of FASD prevention. It also allows us to have things like this digital handbook, on wraparound programs, where we were able to translate the work from a 5-year evaluation of 8 of the sort of level 3, level 4 wraparound programs into a handbook. And lastly, in all of our work, we're always thinking about community-driven and culture-led approaches and what healthy beginnings look like. And so some of you may be familiar with Revitalizing Culture and Healing, but the booklet on the right that we've shown a few times now really describes cultural programming that's being offered in wraparound programming, and describes what culturally grounded approaches in wraparound care can look like, so that we were able to support pregnant and parenting women who are dealing with substance use and trauma. So in this last section, we're going to just talk in the last 10 minutes. We're going to switch gears and talk about what can be useful for you, no matter what field or how you're coming to today's presentation, and really emphasize the use of things like workbooks and toolkits to help you increase your confidence and ability to engage. I've already mentioned doorways to conversation, and so these are 3, one specifically related to alcohol use, but others that are interconnected that we think might be able to help you. This first one here is thinking about pregnancy. This is a toolkit that we came out with this year that is really for folks in the preconception period who are planning a pregnancy. It has accessible language, including why it's important to think about alcohol use, fillable questions, tools and activities, things like that. And so we have, the evidence really excessively laid out about the benefits and harms of alcohol use, but then questions like, what do you like about drinking? Is there something you don't like? And then to supplement that, the process of change, having folks consider what's in their toolbox, what can support them in their change behavior, and how to have conversations. If somebody offers a drink, how you might want to turn it down. We also recognize that this cannot be done alone. So having folks consider who is in their circle of support and writing that down and using that as a way that they can consider how they can achieve their goals. And when we tested this, this toolkit with a number of peers, folks that recently had pregnancies and were planning, everyone asked for mocktail recipes. And so we do have a number of them here. We also have linked to the CanFASD website. They always have a 12 Days of Mocktails campaign. And so that's included for all the mocktail recipes someone might need. Before I turn it to talking about sort of our other adjacent work, I also wanted to flag from a service provider perspective, as that last toolkit might be something you do work on with clients or patients, but it also just might be self-guided. This resource right here was just updated and is just been uploaded on our website in the last 2 weeks. It is an update to our Women in Alcohol sheet, and so it includes evidence on substance, alcohol, health generally, pregnancy, breastfeeding, and parenting. And this we found has been a really helpful resource for providers to have in their hands to use as a quick reference guide that can be used when working with clients and patients. And so just to flag, it's been updated on our website, and we'll have a few others about other substances coming soon. We also have booklets on other substances, and we want to mention these because we know that alcohol is not used in isolation, and a lot of people have questions in the breastfeeding period, and so this booklet, Taking Care, emerged from a project that was about cannabis, but really acknowledged that people do use multiple substances. So it includes information about alcohol, caffeine, nicotine, opioids, cocaine, and breastfeeding. And it, again, includes plain language information about what's known about breastfeeding and substance use, tools and activities to help think about breastfeeding plans and goals, information about trauma, harm reduction strategies, and ideas for engagement with trusted care providers. And from that project, we came with these 3 sheets as well, that in addition to the breastfeeding resource and an accompanying one for service providers, we have these 3 sheets around cannabis and women's health that really, articulate why women use cannabis, some alternatives to cope, and the ways in which women use cannabis. And so again, these are resources that are available on our website that if you are working with clients, you can access, and we really do encourage their use, because again, it really can increase your confidence to engage, and we also are able to provide the research, so we want you to use it, please. So I'll turn it to Nancy to finish us up and talk about the final resource and linking us all back together today.
Thanks, Lindsay. We just wanted to mention this resource that is really aimed at service providers and health system planners in both the substance use field and the child welfare field. And because it really is relevant to alcohol as well. And so I'm just going to walk through these key sections of the workbook one by one, so you can get a sense of what we've tried to do here. One of the things that we really tried to do is to think about centering women's needs and perspectives. And so there's one sheet in the booklet about 10 things that when we interviewed pregnant and parenting women who use substances, they felt it was important for providers to know. It's just a brilliant piece from their perspective about shifting away from stigma and towards support and respect. So it's one, there's a whole section around stigma, and that's a piece of it. One of the other parts of that section is really about practitioners themselves doing some self-thinking, some reflection about their values and their beliefs and perspectives, so that they can see how they might get in the way of being able to work with women. And this has been really popular by service providers in a range of settings, getting together and working through this one together to help us clarify and shift our biases. And then, of course, really concrete to get there to the place of actually reducing barriers. And there's a whole section in this toolkit about what some of the key barriers are that prevent women from accessing the substance use services and the child welfare support that they need. And really talking about, creating a chance for reflection on how each and every provider and service can, think forward and stretch forward to address these in the context of their work. And really, finally, most importantly, is for them to really think about how do they collaborate across the two fields. And Lindsay and I have been doing a lot of training, development of training for acute care providers and child welfare workers about thinking about what does this collaboration look like? What does each field have to know about the other's field, and how can we build relationships and do the work in a really modeling a wraparound approach amongst ourselves, as well as in the services for women. So that is a whirlwind trip through the levels of prevention, the work that's being done to address it in each level, and also some of the tools and information sheets, etc., that we've tried to create that, reflect the work in these different levels. But just in summary, we really do believe that health and social care providers are really well positioned to engage in FASD prevention as a part of what they do. Doesn't have to have a standalone conversation, but can be a really integrated one. And it can look as simple as having a poster on your wall, all the way through to really supporting women to get to live in treatment in the level 4 work. But really important to recognize that all of us can be involved in brief interventions. We can be linking women to some of the new technology supports and other evidence-based materials. And it's really important that we do this to reduce stigma and to make sure that we are really effectively preventing FASD. So thanks.
All right, thank you so much. We do have some questions here. It seems one barrier to women being given correct information about alcohol and pregnancy is that family physicians and obstetricians are not always receiving and sharing correct information related to the risks of alcohol use in pregnancy. Do you see some concrete ways we could change this? Is there a way to get this added to curriculum?
Maybe I'll start, and then Nancy, you can add. Our immediate response is silence, just because we would love to see it added to curriculum. And in some places it is being added to curriculum, but it's not happening necessarily in every jurisdiction and in every program. One of the challenges is certainly that there's not the most up-to-date, and it emphasizes why dissemination of our new guidance on alcohol and health is so crucial, because we've seen from other countries where older guidance is being cited, that is such an opportunity for us to use. We also recognize the immense time constraints that OBs and physicians and NPs all have. And so while we continue to advocate and hope to see more information in curricula that gets disseminated and that there's uptake for, I think it's also really helpful for us to think about who else can be in that circle as a trusted care provider and disseminate that information. And so that's why we think, not only about the physicians, but also about midwives who are extremely well positioned to have these conversations, sexual health workers, anti-violence workers, Indigenous health workers. There's a whole range of folks that can engage in these conversations and be a source of dispelling misinformation. And so the more people that we can get engaged in that conversation, and the more that organizations like yours can invite us to have these, I think the better it is for us to addressing that question in a multi-pronged way. Nancy, I don't know if you have other things to add to that.
I was just going to say that we work really closely with Dr. Jocelyn Cook from the SOGC, who I know is on Health Nexus board, as well as being the scientific director at the CanFASD Research Network with us. And we constantly talk about these things, about how can we make that linkage to the obstetricians and gynecologists and all the others that the SOGC reach in their training and whatever. So we've got lots of ideas plotted to keep on working together with Jocelyn and the obstetricians and gynecologists and primary care providers, etc. But it's an extremely good point that, they are a really important group for us to be making sure that they have the very best information and education around all this. And, I think it also just speaks to just how big a problem stigma is, and our society's just real biases about alcohol and who we think, is at risk, and how we are not that comfortable in having conversations, no matter what kind of professional we are. So we've got our work cut out for us here, as we've talked about today, but I think that it's really hopeful at this point that we are making progress. And I really look forward to working with Jocelyn and others with the obstetricians and other healthcare providers for sure.
Thank you. Next question. I've heard the two fastest growing demographic groups engaging in alcohol consumption during pregnancy are university-educated women in their 30s and college, or university students with unplanned pregnancies. Is this correct?
Well, I don't know whether the very fastest. There's many groups that we're really concerned about, but I think they're a really important group that we do need to think about. And designing things that really do reach and engage them, because I think it's really easy for people who are highly educated to have been imbued with the biases about, that's just a problem for those people over there, as opposed to being about us. And so, I think it's hugely important that we design things specifically for that group. And there are people who we're working with that are really trying to think about the university campus group for sure. A little harder to reach the women professionals once they've left university. But hopefully, if we have these conversations with the guidance overall with everyone, that can reach into their understanding of pregnancy and make that super important.
I think it's also part of what led us to create that preconception booklet thinking about pregnancy. Preconception is a huge area of life, childbearing years, very long period. But if we think about those who are planning a pregnancy and having resources that are tailored to them, those resources are going to look differently than they are for people who are not planning a pregnancy, where perhaps you want to have interventions that are more targeted towards that dual focus on reducing alcohol use and increasing contraception use. Sort of the Project Choices model, and Project Choices in Manitoba created a great booklet available in English and French that does just that for that population. Whereas for us, thinking about pregnancy is for those that are planning a pregnancy and creating information there. So again, getting to the targeted approach and recognizing that these populations are different and why resources and responses are going to have to be different to best address their needs.
Does research support the benefits of a pregnant person's family members also abstaining from alcohol use during these 9 months? Does it improve the pregnant person's ability to abstain?
I'm not sure we have that's been studied well enough to say that definitely that's evidence-based, but it sure makes a lot of sense, doesn't it? To make it easier for women to drink the mocktails or the milk or whatever else they're drinking during pregnancy, if those around them are really supporting that. We do have evidence that it makes a difference that partners are supportive of women, whether they stop their alcohol use entirely or not, but their influence is crucially important. So that network of people around women need to think about what makes most sense. And even to ask the woman themselves, I think would be a great idea. Would it be helpful if I didn't drink around you as well? Would it be helpful if we create some nights to do things that are alcohol free so that you're not denied a social life because you're not out drinking? So I think we really do need to think about how we can be respectful, helpful, and supportive, whether that's completely stopping drinking by other people or not. I do think those conversations are important to have with pregnant women, and to do our best to make it easier for them to choose to not use.
Maybe I could recommend on the CanFASD website a few years ago, we wrote an issue paper on partners' role in FASD prevention, and it does have a section that is related to partners' alcohol use. As Nancy said, we don't have evidence going in that one direction the question was being asked, but it was more about how partners' use can be an indicator for increased use. And so I'd really encourage folks to check out on the CanFASD website that issue paper. I think it's really helpful in contextualizing all of the ways in which partners can influence FASD prevention efforts.
There's still a lot of fear of disclosure because women don't want their baby being taken away. Any resources on how we can have that conversation with them?
Well, I think the conversation we have to have is with the child welfare workers, not with the women in some ways. And really a lot more is being done now around helping everyone to remember that it's not the fact of substance use, it's the impact on parenting that matters. And I think, we can really think about how we raise the conversation with women, and even setting the stage, predicting and preparing kind of them for the conversation of saying, I know that oftentimes women are really afraid of losing custody, and so they're afraid to talk about what their needs are for support around alcohol use. But I just want to, set it up with you that you are not going to be reported for your alcohol use, because that in itself is not a reason for reporting to child welfare. So I think that's the best we can do, really, is to be as genuine and informative before we start the conversation with women and saying, to set that stage that there is safety in that they won't be reported by you in order for you to have the conversation. And as time goes on, if it is necessary to have that dialogue, a lot of the organizations have really moved towards the woman and the service provider phoning the child welfare folks together to talk about what kinds of support she needs, rather than it being something that the provider does alone. So I'm not sure any of it's written down, but there's a lot of good practice that can be used, in thinking about how to set the stage there.
Great. Thank you so much to Dr. Nancy Poole and Lindsay Wolfson for their presentations, and to everybody who was able to join us today.